Good day. I'm Mark. It's a long time to see you. I haven't been in Vietnam for 2 to 3 years. I'm really look forward to visiting in Vietnam, Ho Chi Minh, so soon. And today I would like to give you a special talk about the common diagnostic pitfall for thyroid FNAs. And I'm now the president of Taiwan Society of Clinical Cytology. Next year, I would prepare for an international meeting, so I will forward the information afterwards. The outline of this talk would be diagnostic pitfalls of FNA general introduction, and then I will go through the pitfall in pre-diagnostic preparation and analytic process, and pitfall in post-analytical interpretations, and give you some special examples. Now we go on the first topic, the common pitfalls. The advantages for thyroid FNA, as we know, is simple, rapid, inexpensive, and provide a tentative diagnosis and with minimal injury during our sampling. The disadvantages may be the interpretation based on very few cells, so we need very experienced. We need to train ourselves, our cytotechnologists, our students, to recognize the special diagnosis just based on very few cells. But I think it's our expertise, and it's not so final. If you want to get a final diagnosis, we still need a histological proof by the resection. But at least we can screen out the special cases, the malignant cases. And then for the FNA, we cannot very specifically specialize the type of the lesion and the size of the lesion, especially on some cases. And how common do errors occur in thyroid FNAs? For a study, they point out in their consecutive patients, about 1/4 of patients have false negative diagnosis. I think maybe mostly based on the sampling or the preparation. And about 10% they got a false positive. I think the false positive diagnosis may be based on, some artifacts or some over-interpretation. So the false positive and false negative can result in different outcomes. The false negative, we will miss the case, so we will delay their treatment. But for the false positive, we will give the unnecessary survey and even resection, so do direct harm to the patients. Both of the scenario we should avoid. So according to the meta-analysis, the false positive rate is about generally summarize all the published studies. The general false positive rate is around 4%, and about 5% is their false negative rate. So I think at least for 4% or 5% it still matter a lot, especially for individuals. But we should lower our false negative and false positive cases as best as we can. So we should know where the errors come from. The pre-analytic may be one of the major contributors. The pre-analytic could be incorrect analysis ordered. For example, they order the lymph node FNA, but they sample on the thyroid, and the opposite also occur. They found the thyroid problem, but the sampling is to the trachea or to the lymph node. So the order may be wrong, the sampling may be wrong, and the request may be wrong, and the patient identity maybe goes wrong, especially when they are processing a lot of patients' sample. We should be more careful to label their identity correctly, and the preparation should be appropriately, especially not to create too dry or too crushed slice if they do the direct smears, and mislabeling should be avoided. Sampling collection should be correctly and appropriately, especially you do the liquid-based cytology. You should, collect your sample as best as you can. And transportation is also another point that error may come, especially, the transporter may mess up or may give the transportation labeling into the wrong position. Anyway, the transportation can be another issue. So the pre-analytic may occur the errors very often. But in the lab, during the analytic, we should care about we cannot do the sample lost or mix up the samples. Or sometimes maybe our equipment may be failure. So we should avoid these failures. And sometimes our analytic criteria may go wrong. So this is the training problem, our SOP problem. We should, follow the SOP correctly and routinely. And post-analytic is mostly on our cytopathologists. We should, correctly interpret a case. And if you don't know, if you have very, limited experience in reading these kind of cases, you should consult the other senior pathologists or maybe the other hospitals' expertise. So sometimes you should know where the error comes from and fix up your systemic error as soon as possible. And routinely, periodically, we should look back and pick up these mistakes promptly. So the pre-analytic may be from the patient identity, maybe the labeling problem, maybe the request is wrong, or the testing tube is wrong. Anyway, maybe this pre-analytical problem we cannot control, but we need to feedback to our clinical doctors and clinical departments to make them think about these these systemic issues, and so that they can fix up these problems. So what causes pitfalls? First, the pre-analytical causes mostly on the clinical part, maybe skill problems because they are not so skillful or they are very limited in experience. So the aspiration can go very low cellularity or even acellular. The puncture may be puncture to the inoperate organs include trachea or lymph node or the other nearby organs. And sometimes they can, I think it's very often, they can cause a bloody contamination, make the slice very bloody, so the red blood cells hinder the follicular cells, so will interfere your recognition and reading. And labeling problem is another issue. I think the labeling problem can be avoided if you correctly follow the labeling and the standard of operations. So the labeling problem is, it should be avoided. Preparation, you should teach or train the clinical doctor or technicians to prepare our slides especially avoid the over dry. They should use the fans to dry up the dry standing, and they should put the whey preparation as soon as possible into the alcohol sunks so that our preparation will be in a good quality. So the preparation should be avoided by training, by educating, so that the preparation can be go into a very good quality. And analytical courses may mostly on the laboratory part, and mostly should be careless points, such as you lost up most of your tissues. So maybe the tissue cellularity is okay, but after processing, the cellularity decreased. So if this point come from often and often, our analytical problem will be very serious. So you should train your staff to do as their best to collect and to process the tissue appropriately. And don't mix up the samples. Especially our samples may be some cases may be malignant, some cases may be benign. Don't mix up them together and avoid the contamination. The environmental contamination and the body contamination can be avoided by your processing or by some liquid-based solutions to lower the contaminations. And then the processing should be appropriately be done. Don't make them follow their habitual process, not our standard process. Everybody's habits are different. Sometimes the technicians would like to follow their habits, not our standard procedures. But you should train them not to do it. Because everyone should follow the same process. And the last point, it would be the interpretation problem. The interpretation problem may be based on the inexperience or very careless because they just want to find out it quickly. So they miss up some readings. And sometimes maybe the ancillary test is very limited because they didn't prepare the cellularity adequate or didn't prepare the cell block. So if you have enough tissues, cellularities, you should do the ancillary test as best as you can. If you do the staining ICC or if you do the molecular tests, you can reach a correct diagnosis easily. And consultation. If you didn't confidence in your diagnosis, you can consult senior doctors or the other hospitals supervisors. And then we should communicate our clinical physicians well because they can provide us very good information. Sometimes they didn't write it into the paper so much and even give us the wrong information. But if you can well communicate with them, they will feedback you the correct information, the adequate information to make our diagnosis as correctly as possible. Then we will go on the first pitfalls, the pre-analytical preparations. The pre-analytical preparations will be occur such kind of pitfalls. The first may be blood contamination. You see the blood contamination, they just hinder all the follicular cells. So if the blood is too much, you cannot recognize really this follicular cell easily. And then you will find some ultrasound gel in our slice These ultrasound gel, if they are few or limited, they cannot cause any problem. But if they are much, or they just overlying on the follicular cells, they will cause problems in your reading. And then if you find some skeletal muscles, either in dry stains or the whey preparations, they can be some foreign bodies. If you didn't experience in reading them, you will easily be confused with them. And the different preparation would have different problems. In pumpernickel, if you see the foaming histiocyte or the blood only, you will think maybe this is a non-diagnostic sample. And sometimes you see very abundant colloid. It means maybe it's non-diagnostic, but this can be a colloidal goiter. And if you only see histiocyte only or a cellular, it's definitely a non-diagnostic and unsatisfactory sample. Such cases has been evaluated in many articles. I will point out the Kumar Hospital's article. The Kumar Hospital point out the cystic free only compared to the other non-diagnostic cases. The cystic free only turned out to be less proportion of papillary carcinoma. The other non-diagnostic cases have higher proportion of malignant cases, either in papillary carcinoma or the other follicular carcinoma, mixed carcinoma, or parathyroid adenoma, such as that. So for the cystic free only, I think we should re-evaluate the ultrasound to confirm if this lesion is definitely a cystic lesion. You can observe this for a while and take the FNA maybe 1 year or 2 years after. But if they are non-diagnostic and the lesion is not cystic, you should re-evaluate and repeat the FNA, because the malignant rate is definitely dominant than cystic free only. So for the non-diagnostic, if you just see the colloid, it's maybe okay, because the malignant rate may be very, I think it's relatively low a lot. But if they are non-diagnostic others, you should re-evaluate their ultrasound and do the FNA again to avoid the missed cases. And in the pre-analytical issues, we also include some cases of artifacts, because artifacts such as dry artifacts can make our nuclei very large and very dark. You cannot easily recognize the detail because they get dried. So you will see somewhat most of the nuclei are a bit bizarre, a bit irregular, because the dry artifact. So the dry artifact will cause the loss of the cellular details and make a nuclear enlargement and nuclear atypia. So if the artifact is dominant, you would easy to get the cases into atypical cells or even more severe. So please, during the preparation, you should train the clinical doctor to prepare the slice as soon as they can, to put the slice in the alcohols as soon as they can, because too dry will make our problem. And then if you see the overstaining in dry stain, the dry stain is very dark and very blue. If the standing is very, overstand, you would easily to difficult reading these cases because the overstanding will cause the nuclei very dark, very black. So we cannot to figure out the nuclear changes easily. Especially if you got some cases such as diffuse sclerosis invariant. This will be the dark staining will cause some problem, especially lymphocytes are also dominant. So the dry staining such as Romanowski scans, Dipquick, MGG Ginsa, right stain, new stain, they are not easy to well visualize, especially compared with way fixed Papinicolau stains. But we should keep their dry as soon as possible after the aspiration. And during the preparation, the sampling may be cause some problem after we get the specimen. We found out some chondrocytes and some ciliated cells. If you see some chondrocytes, some ciliated cells, it means our sampling is deep into the airway, especially to the trachea, because the trachea components include the cartilages and include the respiratory epithelium were included into our aspiration slice. And mostly the trachea aspiration didn't cause a lot of clinical problem because we used the needle very small, so the airway leakage will not be cause a lot of problem. But about 0.4% FNA will show this kind of trachea puncture cells, include the thyroglossal and the bronchiosis. In the bronchiosis, the ciliated cell would be easy to be degenerated. So you can see their ciliation, but the nuclear is not hyperchromatic because they are degenerated. But in the thyroglossal the cilia is very eosinophilic because they are well storage, well preserved, so their staining is very good. But in the thyroid FNAs, the cilia mostly are not easy to stain into red. And about the cartilage cells are mostly lacuna cells. So you can see the lacuna with the chondromyxoid stroma, and sometimes maybe they are individual cell with very large pale nuclei with visible nucleolus. This kind of foreign bodies means we should pick them up. They are not belong to our readings, but we should know they are because of the aspiration. Mostly are deep into trachea. So to avoid this kind of skill problem, the Kuma Hospital encourage most of the clinical doctor to do the pararadical aspiration. We should laterally puncture the lesion, not perpendicularly, vertically to aspiration the lesion, especially in isthmus. In the isthmus, they are directly ahead of trachea. So if you puncture too deep, the trachea cells will be included. And then, except some foreign body appear in our aspiration, the aspiration fluid also have some meaning. If you if you want to detect the lymph node metastasis of thyroid cancers, the aspiration fluid can be sent for test the thyroglobulin. Either the thyroglobulin is high or low. The thyroglobulin can be detected in lymph node aspiration. It means the metastasis is happened. So even our aspiration cannot recognize the metastasis so well because very limited cells are typical cells, but the aspiration fluid can be sent to biochemistry and test for thyroglobulin so that we can confidently say yes. In lymph node, we cannot get a thyroid cancer cell by morphology, but the fluid has the thyroglobulin, so they have very high risk and very, very confident metastasis. So these kind of things indicate the FNA fluid can be useful for the ancillary tests. Also include for the medullary carcinoma. If you consider the medullary carcinoma during the aspiration, you can send the fluid to the biochemistry department to test the calcitonin and PTH. So that you can get the medullary carcinoma or parathyroid adenoma just by the calcitonin or by the PTH. And then we go on our pitfall issues in analytical process. Analytical process, I think, because they are mostly in our lab. So if the problem occurs, is mostly because our poor training and not following the standard of procedure. And they didn't do their job well, because we will collect our tissue as best as we can to make a cell block. Because the cell block is always very good for our ancillary tests, especially if you didn't find any benign cell, you find atypical cells only. You want to do more staining, you want to do more tests, but if you have very limited specimen, you can do nothing. So we will try to collect the cell as best as we can. And the equipment, especially for the auto machines, if the equipment is inferior, our liquid-based preparation would be, not easy to prepare in homogeneous staining or homogeneous distribution. So the pitfall in analytical process is mostly because of under-training people and unexpected machine failure. And the post-analytical interpretation is another big problem of our diagnostic pitfall. I think most of the problem will be occur during the interpretation, just because our experience or our training. Because in this era, most of the pathology would be trained to read the red smear. But as you know, the liquid-based slice and liquid-based preparation is getting more and more prevalent. So you should learn to read the sim prep or the short pass preparation. But the sim prep is mostly very flat, and the cluster is very flat because they are prepared under a vacuum system. So they will try to make every fragment into a flat sheet. But the short pass is, they are floating and drop down preparation. So they are easy to get a 3D cluster. So during liquid-based preparation, even though they are in the same preparation, but the mechanism of the preparation has still get some differences. And the reading is also, the criteria, you need to adjust your criteria just based on what slides you read. So anyway, the conventional, simple, short pass, if you get these three preparation in your department, you need to adjust by yourself and with your colleagues, by your case discussion, and by your training, often to adjust your criteria more and more into a consensus. You should have the same criteria and similar criteria, so that you can avoid if you read into the malignant cases, but the others maybe think they just regenerated a tibia. I can get some examples for you. As for the traditional smear in Pumpernickel, you can see the colloid, watery, or the dense. And totally watery would be like this. This one, they will get some glass-like brisks. And dense colloid would be very, condensed and eosinophilic. But in liquid-based preparation, the dense colloid would get more eosinophilic and more fragmented, and the watery background would be disappear into very small waxy fragments. And you can see the watery colloid in liquid-based cytology. They will get into small degenerative fragments, just like artifacts or degenerative debris. So they are totally different. So you should get used to adapt them. And in Pumpernickel or Hashimoto thyroiditis, you can see the lymphocyte predominant background. But the liquid-based preparation, the follicular cells are here, but the lymphocytes are diminished. So the lymphocyte background would be very limited because the liquid-based preparation would be diminish the lymphocytes of the background. And about the about the multinucleated giant cell, in the Pumpernickel we can easily recognize and pick up them up. But for the liquid-based cytology, the multinucleated will get more and more condensed and aggregated. So you should more careful to read them out. And about the papillary carcinoma, you can see the Pumpernickel staining. The papillary structure is very dominant, just like a tree. And the papilla is sometimes very big, just like the baseball bats. But if you put them into liquid-based preparation, the papillary structure will be very fragmented, and the papillary structure will be in a more flat and more condensed, more hyperchromatic nuclei. So the arrangement change a lot, and the nuclear would be get subtle. You can see in the nuclear changes in papillary carcinoma in conventional slice, the nuclear change is just like the same. The grooving is very prominent. The inclusion is easy to pick up. But if you do the liquid-based preparation, the grooving may be very mild to moderate, very subtle. And the inclusion sometimes are not easy to pick up. but their nuclear changes are, generally get more spindle. So compared to the wrong cell, in the liquid-based cytology, if you get some cells in spindleized shape, we should pay more attention to read the nuclear changes, include the grooving, and include the pseudo inclusions. But if you read the conventional slice, the normal cell may not be easy to get too round. They are easy to get a bit enlarged. So we just focus on the grooves or inclusions. So anyway, the criteria, if you do the readings, you should adjust the criteria into different preparation followed by different criteria. And about the post-analytical issue, most of the authors publish the Hashimoto thyroiditis may be the biggest one to cause false positive rate, because lymphocytic thyroiditis would cause nuclear changes and oncocytic changes. The nuclear changes would be get the nuclear enlargement and pelling and somewhat the nuclear grooving, but not so, not every nuclear get prominent grooving, and make us overdiagnose these cases. And oncocytic change is very often in Hashimoto thyroiditis. Mostly will cause the nuclear enlargement and cytoplasm get very, abundant. So generally the cell would be getting enlarged. So a large cell with nuclear atypia would be easy to put them into a typical cell at least. So the lymphocytic thyroiditis are easy to make the cases into severe or atypical categories. However, because the Hashimoto thyroiditis have higher papillary carcinoma association compared to the other issues, so sometimes it's very tricky if you read papillary carcinoma in Hashimoto background, because they easy to cause the nuclear changes, but they also have higher malignant associations. So the diagnosis interpretation is totally based on your experience and your reading. You should read this kind of cases carefully. The Hashimoto thyroiditis mostly, they are in the background with heterogeneous lymphoid population. But the other differential diagnosis would be the lymphoma. The lymphoma include the martoma or diffuse large B-cell lymphoma. They are easy to be monotonous population. So you should, if you do the conventional slice, you just need to carefully read the background cell about their heterogeneous or monotonous and their variation and their lymphoid proportion. If the lymphoid proportion is dominant and they are monotonous, you should mention the possibility of lymphoma and put this case into at least a typical cells and warranted them to do the lymph node or the lymphoma studies. And then I will go through some cases of special cases. The first case is 56 female, a right thyroid tumor, You can see the right thyroid normal part is here, and the tumor is over here. The tumor is around 3.7 to 1.1 centimeter, and you can see the tumor is well defined with relative hypoechoic texture. The tumor didn't have calcification, and we do the conventional papillomastoid staining. You can see the background relative is have a lot of naked nuclei, and the structure is relative into papilla or sheets-like structure. This is sheets-like structure. This is papilla-like. The background may be lymphocyte or may be naked nuclei. Let's go into the high power. You can see, yes, the background have some, some lymphocyte-like structure, but not so dominant. The solid sheets didn't have colloid-like structure, colloid-like content, but some pseudo-follicle-like structure, but didn't have colloid. And the other parts, you can see some small microfollicle-like structures, some flat sheets, and the background lymphocytes. And look into the highest power, you can see, yes, maybe these are, degenerative cell, and maybe this is degenerative debris or colloid, but I didn't see the colloid in a microfollicle, but the nuclei is very round and even paper like chromatin. So if you see, a structure in solid sheets or papilla-like structure, but you didn't see the nuclear changes of papillary carcinoma, they are round and paper-like, you should consider parathyroid. Because the parathyroid always have a very round and oval nuclei, and their chromatin are usually very paper-like, very fine, and their nucleolus is not so prominent, and their cytoplasm is limited, always mild to moderate. So they are looking like carcinoid tumor, but without any prominent atypia. So this is very high power. You can see the chromatin is very fine, and cell to cell border is indistinct, and the cytoplasm is relatively pale, and we didn't find any confident colloid, even though this is microfollicle-like. So what's your answer? What's your diagnosis of FNA? If I do the interpretation, I will say maybe they are a typical cell, and I favor it's a parathyroid lesion or into benign, and mention maybe they are, parathyroid lesion with especially parathyroid adenoma, but I'm not so sure they are parathyroid carcinoma or others. Or if you can put them into follicular neoplasm because the severity is relatively higher, and you are not so confident they are not follicular cell, If you think they are follicular cell, you can put them into follicular neoplasm. But you should not put them into suspicious because their nuclear changes are not like papillary carcinoma or oncocytic carcinoma or follicular carcinoma, and positive even far. And we do the cell block. The cell block tell us, yes, they are eosinophilic cell with round, uniform nuclei. And sometimes you can see the follicle-like structures, but without colloids. And we do the chromogranin. The chromogranin is positive. So they are parathyroid. You can also do the synaptophysin or the GATA3. The GATA3 is very useful, especially as a nuclear staining. Nuclear staining is more, is more trustable and reliable because cytoplasm staining such as chromogranin sometimes would be heterogeneous or not easy to be stained in the ICC. If you do the ICC, you can do the GATA3. And this case eventually get a resection. And after resection, you can see the thyroid is here, the benign thyroid part, and the tumor is here. The tumor is well defined and compact, solid structure with some follicle-like structures. And then they are composed of, cystic changes and follicle-like structure and clear cell changes, oncocytic changes, but the nuclear changes are very fine. You can see the nuclear changes are always round, oval, and paper cell-like. So we would recognize the nuclei not by the cytoplasm. The cytoplasm may be clear, may be eosinophilic, but the nuclear changes are always round, uniform. Chromatin is fine. So if you want to recognize parathyroid cells, please look at their nuclei. So this is a parathyroid adenoma. And clinically, they have very high calcium, free calcium. The characteristic for the parathyroid cell would be uniform round cell with indistinct borders, paper cell-like chromatin, and indistinct nucleus. And mostly they are cohesive solid sheets or microfollicle-like structures without colloid. And for the staining, you can do the TTF1 to exclude the thyroid cell and GATA3 to include the parathyroid cells. And you can also do the neuroendocrine markers and PTH. But PTH is not commercially available. And this is a table to tell you how to differential diagnosis parathyroid adenoma, papillary carcinoma, or follicular carcinoma. Mostly their cellularity are hypercellular. And pattern sometimes may be very overlapped, especially for follicular lesion to parathyroid. They have syncytial solid structure and bare nuclei. Bare nuclei is not easy to occur in thyroid follicular lesions, but bare nuclei are frequent in parathyroid adenoma. Papillary carcinoma, you can recognize its nuclear changes, and the bare nuclei is not easy to be found. And the structure are also, papillary carcinoma have papillary structure. Parathyroid are mostly overlapping nuclei. Paravascular arrangements will be mimic papillary-like structure. Syncytial solid will be overlapped with thyroid follicular lesions, especially these parathyroid to follicular lesions. And the nuclear of cells are the biggest difference. The parathyroid will be small and monotonous uniform ground, but the papillary carcinoma has, enlarged cells with ground glass nuclei and nuclear groups with pseudo inclusions. So the follicular cell will be enlarged and have very coarse chromatin, not fine chromatin. And the cytoplasm is relatively scanty and sometimes will be eosinophilic. It depends on its oncocytic changes, happen or not happen. And the background colloid should be happen in papillary carcinoma and follicular carcinoma, but not present in parathyroid region. You can see sometimes some protease material is because of the hormone secretions. Okay, let's go to the case 2. The case 2 is thyroid FNA from a 39-year-old female right thyroid lesion. You can see the anti-thyroglobulin is very high, the thyroglobulin is low, and the free T4 is normal, TSH is normal. So this case is autoimmune thyroiditis case. She has multiple hypoechoic nodule and with unclear margin and heterogeneous echogenicity. So you can see in the right thyroid, total right thyroid are heterogeneous and have some calcified-like spots and some white fibrotic areas. And I do the liquid-based cytology for this case. Especially this is autoimmune thyroiditis case, but in the background you can see the lymphocytes are not so prominent because this is a liquid-based preparation. I do the BD show pass, so the cluster of follicle would be more 3D dimensional. The follicle here maybe just like a typical. And look the other area, you can see, wow, this case has some eosinophilic cytoplasm, and the nuclear change, the nuclei is enlarged, and maybe have some nucleolus. And into the high power, you can see some grooving, and the colloid is not so prominent. And you can see some enlarged pleomorphic cell, but I didn't find some inclusions. So what's your answer? I think this case is very difficult because this is an autoimmune thyroiditis case. Autoimmune thyroiditis can cause nuclear atypia. So this nuclear atypia may be regenerative, reactive, but the echogenicity and the ultrasound finding tell me this whole thyroid gets some heterogeneous spots, calcified or fibrotic. So maybe the calcified and fibrotic area cause some problem of aspiration. So we cannot get so many hypercellular cells. So I can only read this case upon these atypical cells. So I will cite it out as a typical cell because I am not confidently assured this case is not malignant. And this is the recession right thyroid. It's very firm and the texture is very hard and relatively white. And after resection, you can see they are fibrotic, have a lot of hyalinized stroma. And the lymphocytes are very prominent to cause lymphocytic could cause a follicle, and thyroid follicles are relative atrophy and get some, Herschel cell-like changes. And the other, picture tell us, yes, the sclerosing background is prominent. And look into the high power, you can see the nuclear changes is prominent. They got enlarged nuclei and visible nucleolus and irregular nuclear shape. And you can see a lot of lymphocyte-like infiltration, and mostly are plasma cells. These plasma cells make me very curious. Is these plasma cells are normal plasma cells or IgG4 thyroiditis? Because the IgG4 thyroiditis can happen in Hashimoto thyroiditis, rhinothyroiditis. This case may be like a rhinothyroiditis, but the rhinothyroiditis, the sclerosing should be very prominent, and fibrotic bands should be into the adjacent organs, just like trachea, muscles. So this case is lymphocytic thyroiditis with prominent lymphoplasmacytic infiltration. So you can see many plasma cell-like cell infiltrate and prominent nuclear polymorphism. And we do IgG4 staining with ultra fast rate for the second level antibody. You can see dominant infiltrate of IgG4 positive cells. I think every high power is over 50 cells. So this case was signed out as IgG4 related fibrosing variant of Hashimoto thyroiditis. The Hashimoto thyroiditis, if they get very prominent fibrous expansion, sclerosing backgrounds, can be fibrosing variant. And the IgG4 related thyroid disease should be fulfill some criteria, and the IgG4 related thyroiditis can be covered into the rhinothyroiditis, fibrosing variant of Hashimoto thyroiditis, or IgG4 related Hashimoto thyroiditis, or Graves' disease with elevated IgG4 level. And the criteria of IgG4 related thyroiditis would be enlarged of thyroid. Yes, this case have enlarged of thyroid. Hypoechoidogen in the thyroid by the ultrasound, yes. Elevated IgG4 level over 135. This case is not detected because we didn't measure by the biochemistry. But the histology, yes, they have prominent IgG4 positive plasma cell over 20 cell per high power field, or the ratio to the IgG plasma cell would be over 30%. And so this case is relative probable, or probable case of IgG4 related. So if you see some Hashimoto thyroiditis, you should check out for the IgG4 positive cell, especially when the plasma cell are prominent. Okay, let's go to the case 3. Case 3 is a thyroid FNA from a 60-year-old female. The left thyroid tumor. You can see the left thyroid is enlarged, very large. And I didn't find the normal part. It's very big and heterogeneous. And the aspiration of conventional smear are very bloody, so you can see the blood hinder the follicular evaluation. But the cells are relative in the solid sheets. And in the the other parts, you can see very bizarre cells with very prominent large nucleolus. This cell is relatively like, not like a papillary carcinoma, but like a squamous cell carcinoma. And this cell sometimes is very bizarre because they have very multilobulated nuclei. And the cell to cell seems to have, intercellular bridges. So I would think it's more like a squamous. So you can see the atypical mitosis here. But in the other part, I can see some vacuolated cytoplasm. Maybe they are mucus cells. When you see a squamous component and now you see the mucus cells, you will think about mucoepidermoid carcinoma. Mucoepidermoid carcinoma or adrenal square also can occur in thyroid glands. And the other part also show the mucus cells. So, what's your answer? I would think it's suspicious for malignancy or positive for malignancy because I suspect it's a mucoepidermoid carcinoma. Yes, the CT scan will be show this case is very large tumor. This is the endotracheal tube. The whole thyroid lobe are occupied, especially in the left side, are occupied, and pretrachea and posttrachea area are also invaded by this case. So the extrathyroid expansion is prominent. And the right thyroid is very limited and also involved. And after the total thyroidectomy, you can see the normal thyroid are here, and the tumor part are here. You can see the tumor part have some, some cystic and mucus components, and the stroma have some, some squamous infiltration, the squamous cell-like infiltration. The other part have cystic and mucoepidermoid carcinoma-like epithelium infiltration, have some goblet mucus cells. And they also have some eosinophilic infiltration. So it's a sclerosing background with both squamous and mucus cell components and some eosinophilic infiltration. So this case is a SMAC, sclerosing mucoepidermoid carcinoma with eosinophilia. They mix up the squamous and glandular differentiation. They have very fibrohyaline sclerosing background. And the tumor inflammatory cell infiltrates with eosinophilic cells. They have very prominent, this kind of case have very prominent lymph node metastasis, extracapsular spreading and vascular invasion and perineural invasion. Very common, but the days due to the disease is uncommon. It's very tricky. They are not easy to be found in Hashimoto's thyroiditis. Their mutations are not commonly detected. Especially, they didn't share the common mutations of papillary carcinoma, such as BRAF. They didn't have BRAF mutations. And they didn't have MAML2, because the MAML2 mutations are often occur in salivary gland mucoepidermoid carcinoma. So the SMAC is a distinct entity. They are believed to be a rise in the solid cell nest. Okay, let's go on the last case. The last case is a 69-year-old female, the right thyroid tumors. The right thyroid got two nodules. One is here, the two is here. They have a central hypoechoic area, but The nodule 2 is relatively complex and get some calcified spots, but the nodule 1 is relatively homogeneous. This is the aspiration from the nodule 2. The nodule 2, the perpendicular staining shows some, the papillary structure, some papilla-like, and some fat adipose cell-like, cells. And the high power, you can see, yes, the nuclear grooving is very prominent, and inclusion is here. So the nodule 2 may be a papillary structure, papillary carcinoma. And this is a large adipose cells, adipocyte. And in a liquid-based study, you can see some, some skeleton muscle. And this is papillary structure of tumor. And in the high power, you can see the grooving is here, grooving is here. This is, the papillary carcinoma, especially compared to the conventional smear. We see the inclusions. And the other part, we can see the bubble gum-like inclusion. Yes, we can pick up a very beautiful inclusion here. And the Leusten, we also do the Leusten. The Leusten also see some pseudo inclusion here. And the structure is relative papillary structure. Yes, you can see some, grooving, inclusion, and inclusion here. So the nodule 2 is a papillary carcinoma. So what's your answer? I think this case is very easy. The nodule 2 from our exploration of 3 different preparations, just want to tell you one truth, is positive for malignancy. It's a papillary carcinoma. But our story is not based on the nodule 1. Well, it's not based on the nodule 2. Our story is on the nodule 1. The nodule 1 is a cystic lesion, but you can see the nodule 2 is papillary carcinoma. Yes, the growth is perfect. But the nodule 1 is a fat-like structure. It's just a cystic and adipose structure. Adipose-like content. Sorry, not structure. Content. And then you can see the nodule 2, yes, is a papillary carcinoma. Here in the low power, in the high power. And you can see some calcified spots. And BRAF is positive. But the nodule 1 is a cystic lesion, but the content is thyroid and adipose tissue. The adipose tissue are composed of the mature adipocytes. TDF1 is positive in the thyroid follicles, but negative in the adipose cell. BRAF is totally positive, negative. So this is thyroidlipoma, or you can see the adenolipoma of thyroid. So this case is a synchronous papillary carcinoma and thyroid adenolipoma. And I think only 6 cases are reported of this synchronity. This case is my case, but I put this case to Dr. Cook. Dr. Cook-Mayak. Dr. Cook-Mayak is from Poland. From Ukraine. And now she is a resident in McGill University for the pathological resident training. And her supervisor is from Vietnam. It's Dr. Vong. I always call him Dr. Vong. Dr. Vong is Vietnamese, but he's very excellent and senior McGill University pediatric and endocrine pathologist. He is one of my best friends. We are very close friends. But it's a pity to meet him, especially in recent 3 years. I cannot attend USCAP, so didn't meet him in person in recent 3 years. But I share this case to them, and Dr. Cook write this case, and I propose this case, submit this case to diagnostics, and eventually next year it was published. So I would like to, appreciate their cooperation and our connections internationally. I would like to thank you join my talk, and I would encourage more Vietnam pathologists and young pathologists to share your case and study with me. If you want to publish more and more international articles, you can find me, and I will be always here to help you. Thank you. This talk is come into an end. If you want to figure out more diagnostic pathway with multidisciplinary discussion, you can check out with this checklist. And then I would look forward to joining our South Vietnam meeting as soon as possible. Thank you for your friendship, and be safe, be healthy. Good day. See you. Bye.